Questions about diabetes and peripheral artery disease answered today live with Dr. Manessis from New York. Thank you so much, Dr. Manessis, for being here. I want to get started with just first, we have a lot of patients here with questions, but first, anything top of mind, any lessons based on, the past couple of weeks and patients that have come to see you that you think, hey, you know what, everyone just needs to know this.
The last couple of weeks. I will say that the most important thing is to be able to educate patients about the complications of diabetes and how early they can start, even before VA1C is above 6.5. So that's what I've been doing a lot lately, based on new studies indicating that even prediabetes is associated with microvascular complications, and remission from a diabetic state to a pre-diabetic state, or from pre-diabetic to normal glycemia, is beneficial to everybody.
Why is it so important? We just had a patient that is not here right now, but is getting ready to go in for a procedure, and her A1C was high, and she was concerned going in for a procedure to open up her arteries. Her doctor saying the likelihood that it's going to close within a couple weeks is just too high with your A1C above 8. Why is it dangerous to perform a procedure if your A1C is too high for your presentation of disease?
This was supposed to be a angiogram type of angioplasty, or an open surgical
Angioplasty.
angioplasty. So the higher the sugars you are, the more think about it, the thicker your blood is, the more likely that you're gonna, whatever caused the initial closing of the artery, it will continue doing the same thing by accumulating more inflammatory markers that will make sure, will help the plaque regrow again, and then of course close. So it's a matter of, your sugars have to be good for two reasons.
Yeah.
One reason is because it makes healing better. And second thing is, when your sugars are good, there is less virtuosity in your bloodstream, which means there's more clear blood flow and less chance that you're going to have more clots form because your sugars are high.
Okay, we have quite a few people we want to have jump in here. We have Derek that is we're going to have him unmute. He has quite a few questions for you about not only diet, so maybe Dr. Jean Chen, our diabetes educator, your diabetes educator, but I'd like to own her too because she's amazing. She might want to jump in as well. But Derek, meet Dr. Manessis.
Hey, doctor, how you doing?
Hi, Derek. How are you? Thank you for joining.
I'm all right. A little better. I just recently got off of having a Achilles tendon lengthening surgery, so I'm a little wrapped up right now.
I can definitely see that, Derek.
Just wondering with the offloading, what percentage of chronic plantar diabetic ulcers fail simply because somebody can't, be adequately offloading? I mean,
that might be a Dr. Chen.
Yeah, or whoever can.
Can I address that?
Sure.
Okay, so offloading is very important because what you're trying to do is distribute the plantar pressure away from where the foot ulcer is and distribute it more towards the knee. Because if you're not taking that pressure off, so just imagine, like, let's say you take your finger and you press against it, right? What happens to that fingertips? It turns white, right? So that means less blood and oxygen and nutrients is getting to that area. So when we offload it, what happens is that you're now allowing oxygen, nutrients, and what you need for wound healing, increasing the oxygen supply to the area so that angiogenesis, which is building new blood vessels, can develop. Also, if you're not offloading the area, every single new tissue that you're developing, the pressure and the sheer force of walking is just going to destroy that. So that slows down your healing. So offloading is number one, aside from nutrients and blood sugar control, to have wound healing. Another problem is that if you're what we call equinus, meaning that you're putting more pressure on the forefront of your forefoot, okay, that's called equinus, and your heels up a little more, that's placing pressure in the forefoot area. So in some people, Achilles tendon lengthening procedure is needed to decrease that pressure on the forefoot so the ulcer can heal. And also people with transmetatarsal ulcerations, there are studies that are showing that it is now a secondary procedure in addition to transmetatarsal amputation to help the area heal and decrease the chance of recurrent ulcerations. I don't have the exact statistics. David Armstrong is a leading proponent of the tendon Achilles lengthening. So you could do a little research on David Armstrong because he's one of the first people to propose that. So I hope that helps answer your question.
Yeah, definitely. And that's exactly what was going on with me with the, having a TMA. And the podiatrist I got said that everybody that has a TMA gets the wound in the exact same spot where mine was because of the Achilles tendon is pushing down, it's pulling the heel back up. So that's exactly what went on with me. And I just had the procedure last week. So
I
hopefully
wish you
that'll clear
speedy
this up.
healing.
Well, thank you very much. I appreciate that. Been a long road, that's for sure.
Yeah. So you had some questions also about controlling diabetes and diet. Do you want to throw those out there?
About the bread.
Oh yeah, with how bread and sugar, hey, you threw me off there for a second.
Sorry.
Yeah, with the bread and sugar, it's just you have to stay away from that. I don't know if it's really a question, but those are horrible for you. I mean, people talk about gluten and stuff in bread. The first word letters in there spell out glue. So I mean, yeah, that definitely makes your blood a lot thicker and everything, and it's just a detriment, and all those years, oh, eat this bread, eat that bread. No, don't eat any bread. Garbage.
Dr. Manessis is like, yeah. But what
You
about
don't need
the
me to
medication?
tell you that. Okay.
I know, isn't that good to hear him say it?
But
So-
definitely the diet is an important component of if you have diabetes, you have to be very careful what you're eating, especially with processing foods with a high glycemic index.
But with the medication, what is the medication that you were asking about that you've been on it, Derek, and you're not sure if it's working, they're just upping the dosage. He can answer a question about that.
Yeah, the metformin. It's 500 milligrams twice a day. Now they want me to do a third one every day.
You only what's your A1C?
This last time, a couple years ago, it was 11. Now it's down to 9.5 this last month. I don't know what it is right now. I haven't had it checked again.
So the last couple of years, it's been
Yeah, it was really
9.
high. Yeah, it was really high.
But it's still high. That's the thing. And you're
Yeah,
eating.
it's
I mean,
still high.
you're
And
eating
yeah,
right.
I'm not. Yeah, I'm trying to eat everything that I'm supposed to be eating and not touching any of the bad stuff. And I just look at food, and my A1C and everything goes up.
The liver is what?
Yeah, what else can possibly make that go up besides the food? I mean, can my liver do something and make it go up?
Absolutely, but you need better management. We need better medications. Going up to 3 times a day metformin is not going to decrease your A1C because your target should be less than 7 first phase. So you need more aggressive management.
What are some of the things that he should ask his doctor in terms of maybe some medications just to consider? Maybe they just they're not an endocrinologist.
I don't have his labs. I don't have his history. Okay, his past medical history, past surgical history. But he definitely should ask him, if my A1C is it's still 9, is it time to start a new medication like a GLP-1 or an SGLT2 inhibitor, anything that can help him manage his sugars more efficiently and help his pancreas secrete insulin because, yeah, metformin doesn't work at this stage. Doesn't mean we should stop it, but it's not going to do it.
Asking about
Yeah.
PGA and fiber.
So what about fiber and a fiber pill called PGX? I'm not
You know,
sure the exact name.
fiber pills, whatever you eat or you take fiber doesn't really matter, okay, because fiber doesn't have a very high glycemic index. It's more important, it makes you feel fuller. It's more important for mobility of the GI tract. But yes, it may decrease your sugars, but it's like eating potatoes versus eating vegetables. Okay, if you're going to eat plain potatoes, your sugar's going to go up. If you're eating vegetables, they're probably not going to go up. So fiber is fiber. Okay, but the issue here is what's the cause of your diabetes? Okay, and how we can deal with it at the level of the pancreas.
They can
Yep.
determine, they can determine.
And,
what the cause-
And
The doctor can determine what the root cause of that is. I mean,
Usually endocrinologists in that case will be able to determine that. Okay, but yeah, there is a test that you can do to see how well your pancreas is working.
Okay.
yeah,
Okay.
an NP may not be enough for you at this point. We might need to have her send you to an endocrinologist. So that might be helpful. Let me get to Nancy. Nancy, you have a few questions here.
Yes, okay.
Remember, he can't give medical advice, and so he can only help you with some information to understand something better and questions to ask your doctor. So go ahead.
I don't think I'm muted. Can you hear me?
I can hear you.
Okay,
I can
great.
hear you.
All right. Okay, doctor, I'm a 25-year diabetic. I have lipoprotein little a. I'm in a clinical trial with Eli Lilly. And I've been able to get I've been on Ozempic for years, and I've been able to get my A1C down to 6.4. I'm on 4 medications: Ozempic, Farxiga, metformin, and glimepiride. Now that I'm down to 6.4, is there any way I can get off? Do you think that I can get off some of these medications? I eat very healthy. And my problem is because of everything that's happening with these Medicare subsidies. And also I was getting my Ozempic free for 4 years. And now they did away with the program last January. My doctor's been helping me get the Ozempic because I cannot afford it. It's close to $200 a month. Now they're coming out with all these Wegovy, Mounjaro, all these different things, and they're lowering the price down to $50 for weight loss, but they're not helping the diabetics. So at this point, I'm going to even work harder to try to get my A1C down further. Do you think I'll ever be able to get off some of these medications? Because I just can't afford them all.
Okay, excellent question. It sounds like you're doing a great job because your A1C is down to less than 6.5. So you're working hard to keep it there. The GLP-1s are definitely an effective way of being able to decrease that A1C. If you're already on the study, you can ask them you can try to tell them if they can pay you for the medication. Okay.
The study that I'm in is for the drug lepodisiran with Eli Lilly. And I don't know. So they might pay for something like that, or I don't.
Yes, you can ask them, you know what, I cannot afford the medication. And, I'm going to have to stop the medication, drop out, figure out if, just give them any excuses, something that they can really, sometimes they do pay medications. Okay. They do pay for medications. How's your Jardiance? How much they charging you? Farxiga, sorry. Are you in Farxiga or Jardiance, you said?
Well, also Farxiga is now, I was getting that free I'm getting it free up until the end of December, and they also are now dropping it. They are no longer going to offer that program. This is what a lot of us are running into. Novo Nordisk has dropped us, and now AstraZeneca has dropped us. And so it's like, what's going to happen to all of these diabetics that have been getting medication and we can't afford it?
With AstraZeneca, there is generic now, DAPA.
Okay.
There's a generic Farxiga, which is cheaper. Okay. Not much cheaper, but it's definitely cheaper. Okay. So that's one thing how you can proceed. You can tell your doctor to
Mhm.
switch you to the generic, and then you can compare prices. Now, Medicare is Medicare. Usually adjusts your copay based on what tier that drug is. So, but definitely it should be much cheaper than it was Farxiga.
Okay, and Ozempic, I think, is still tier 3.
It is tier free.
Yeah.
What else we can do with that?
Yeah,
You can
I
ask
do.
Eli
I
Lilly, who's doing the study, if it can help you pay for that.
Yeah, I will. I'll check with that. And I do see an endocrinologist PA. She's very good. And she did a blood test on me when I started seeing her 4 years ago. And she said, your pancreas is still producing some insulin. So that was good. And I've just worked really hard. But it's like every time I get stressed out or if I get sick, I had skin cancer surgery last January. Everything makes it go back up. So I went right back up to 7.4. But by June, I was able to get it down to 6.4. So I just work very hard at diet, walking, exercise, the whole thing, so.
So what you can do is,
Frustrating.
yes, definitely stress gets you, make your sugars go high. That's for sure. But one thing for sure, if I was you, is I will call your insurance and figure out about the Farxiga, about the generic form, how much they're going to
Generics.
charge you. What's the
Okay.
negotiated price? Okay, because I have a feeling it's going to be much cheaper than. Unfortunately, with Medicare Part D, we have an annual out-of-pocket cost, which is about $2,000 to
Yep.
$2,100.
Yep.
So we have to pay that before they start helping us out more.
Right.
But there are extra help beneficiaries may pay a little bit less. You should call your Part D program and discuss how much is generic Farxiga. Okay.
Yeah. Ozempic is the major problem. And, I'm 73 years old. I'm already back to work. And, this is tough. It's a lot of stress. And I'm just wondering, how am I going to pay for this? And
It is.
how am I going to go off of Ozempic? And, I've even talked to my endocrinologist about going on something else like Mounjaro or one of the others. And she feels that because of peripheral artery disease and everything that I have, that it's important for me to stay on Ozempic. So this is my dilemma.
Can I add
Yes.
something here?
Yes, you can.
I was talking to Maggie, who is a pharmacist at Endocrinologist. She's waiting to get information from her sister about some kind of Medicare gap that's coming out to exactly address this issue, because I brought up one of my patients with her about this issue. So we're waiting to hear that. And she said some pharmacies participate in it, some pharmacies don't. You may want to talk to like different pharmacies that when this is coming out. But when I get this information from Maggie, I would definitely give it to Kim to share with you. Okay.
Thank you so much. I'd appreciate any help. And I think you're going to see a lot of people facing this coming up in the next few months. And we're going to be looking for, different plans. And I do that every year. I'm trying to get the best plan. But of course, our deductibles are high. And then to pay $200 on top of that and a very high insurance also, it's really tough. So my goal is to get off some of these medications, so.
Yeah,
Yes.
I get it. I get it. My Farxiga is really expensive. My insurance used to cover it. And this year I switched to the generic form in order for me to afford the Farxiga.
Okay. Well, I definitely will do that. I will look into that. And I'd appreciate any information that you could get, for
And
me.
thank you for helping to bring that to the forefront, as well, Nancy. It's really important. Okay. Sally has a couple questions here. Sally, go ahead. Did he jump off or is he still there? Here's Sally. Hi, Sally, all the way from Cape Town, South Africa. Meet Dr. Manessis and Dr. Chen.
Hi, doctors.
Hi, Mr. Salih.
Hi there. Just a quick question on some of my research that I'm doing, just to understand things better from another endocrinologist or another doctor's point of view. I'm doing research on obesity as a major upstream driver of disabilities. And these disabilities are in diabetics over the years that, we have hearing disabilities, if you're obese, you have mobility, you know.
I gotta eat dinner.
So my question is
I
like,
haven't eaten. I need to go eat and come back.
Well, we have a little, there we go. We have to mute some of the
yeah,
other microphones. Sorry about
okay,
that. So what is your question?
no problem. Okay, we often hear about obesity in type 2 diabetes, but many people living with type 1, like myself, diabetes, I actually suffered with, or still suffer with obesity and it's insulin resistance. How should clinicians approach obesity treatment in people with type 1 diabetes, and why is it still overlooked?
Okay. You already know that obesity is one of the strongest risk factors for developing type 2. We know that. Why?
Yeah.
Excess adipose tissue, excess, especially the visceral fat, the bad fat, promotes insulin resistance, okay? Chronic inflammation and metabolic dysfunction, which makes it harder for our insulin to move and push glucose into the cells. So that's key. That's the key feature about that. Now, with type 1 is when you don't make any insulin. Okay.
Yeah.
So the question will be, okay, so how type 1s gain weight? They gain weight because in relationship to what we're eating, we are using more insulin, and eventually we gain more weight. And as we gain weight, we become obese, which makes it a vicious cycle. Okay. So because even type 1s can become obese, but type 1s usually do not start obese. They become as the years progress. And yes, they develop excess adipose tissue, they develop sometimes visceral fat, and eventually they also develop insulin resistance, okay, which makes it harder for the insulin to move food into the cells. Of course, the pancreatic cells are not working for them, so it really has nothing to do with the ability of the cells to compensate because they're not working, they're not making an insulin. But you still can develop insulin. So it's becoming, the last 4 or 5 years, it becomes more and more evident, and more literature comes back into they need to treat type 1s also for obesity, to decrease their insulin resistance, to make their insulin that they're getting exogenously more efficient. Okay. So yes, that's become more and more common and more prominent lately.
Thank you very much for that, because I never understood why, as a type 1, why they actually put me on metformin for a short while. And
You know,
no, go on.
Because that's until 2012, 14, we really did not have any other medication that we can deal with insulin resistance. We thought that metformin was the best drug. Okay, but actually over the last 20, 25 years, we know that metformin is not a good insulin sensitizer drug. What it does is decreases gluconeogenesis, glucose production by the liver. So the GLP-1s, however, are the best drug that we have right now that can really help us with insulin resistance. Okay, they're much more efficient. They can decrease insulin resistance. They can help us with better insulin signaling, okay, decrease inflammation, and break down fat.
Well, thanks for that. Thanks for that. You know why? Because in South Africa, we're fighting for better medicines like the GLP-1s. And if we go to the public hospitals, they will just give metformin. And you've explained things so beautifully, and the understanding, of why we actually become insulin resistant. But fighting for the medication that we actually need has become the crux of the matters. They will just give us the basic metformin, and that is it.
Even here, Mr. Salih, there is no approval for type 1s to go on GLP-1s. There's some private insurance that may let you do that. Okay, but usually they ask for a lot of information. Okay, there are studies right now that some of the pharmaceutical companies are doing, especially like Lilly's doing one on using Manjaro in type 1s, tirzepatide in type 1s, and that should be out by next year.
Thanks very much.
You're
So,
welcome.
Salih, before we get to the final question from Douglas here, you have a challenge actually for Dr. Chen and Dr. Manessis.
Should I leave? No, I'm just kidding.
Are you going to do it, Salih? You got to come back on. You muted yourself. There you go.
Oh, sorry. There we go. Okay. I think I'm going to bypass this one and leave it to Douglas. And
Do you want me to do it? So we're going to do the Great Circulation Challenge, and I think you heard of it.
Okay.
So the Great Circulation Challenge. I'm going to out you first. So the Great Circulation Challenge, he launched the diabetes and obesity team to raise awareness that diabetes and obesity can lead to PAD, lead to vascular, cardiovascular problems. So he was thinking either one, you guys can just join his diabetes and obesity team and help us rally support and get as many people on that team as possible, or you can start a U.S. diabetes and obesity team and rally the troops here. He'll rally the troops there and even maybe get the folks from the UK to start their own diabetes and obesity group. And maybe there's a way we can do a prize for the fastest team, or just bragging rights.
We can definitely, that's a great idea.
Yep, I think it'd be really fun. Because the Great Circulation Challenge, we're going to try to travel the 60,000 miles of superhighway in our body. And, when we have the leaderboards, the people at the top of the leaderboard, they're going to raise awareness for whatever team that is up there at the top of the leaderboard. So the goal is going to be to get diabetes and obesity up to the top. So it's constantly being talked about, right? Yeah.
Yeah, you've actually said it so beautifully that I've actually fumbled my words. And I've just spoken to one of my professors at the university because I'm actually taking this very seriously in the diabetes, obesity, and how it's actually leading to peripheral arterial disease and the disabilities. And she's actually semi-approved things, and I spoke to her about the challenge that you actually suggested last night. So thank you for that. And it is something that it just actually works with me over the years of 44 years of being a type 1 diabetic and going through all the complications. And this challenge is actually very fruitful for me. Thanks, Kim.
Yeah, excited to have you guys. So we'll let you know. You guys talk amongst yourselves, Jean and Dr. Manessis, to figure out whether you're going to do a U.S. team or whether you want to just join the forces and make it an overall diabetes and obesity team across the globe. But one more question here. We have Douglas. Thank you for being so patient. Douglas, go ahead and unmute and ask your question.
Yes, I have PAD, CAD, and I'm pre-diabetic. But I also have CAD, atypical hypertrophic cardiomyopathy. Now, I don't know if I'm fixing to throw a hand grenade in all this mishmash that I've heard. That is great information, but I'm having ED problems. So what is there a direction that I can hit? I had two bypasses, an aorta bifemoral and an axial bifemoral. And through this process of having all these things, I'm having those issues as a man and trying to find information about what I can do and some direction in that sense. That I hope I made sense.
So the most important thing is, Douglas, I will definitely get my sugars under better control. There is no, otherwise nothing is going to make it better, PED. So because you probably can have a neuropathy, you probably can have what we call, you definitely may have vascular disease. There's a multifactorial and definitely can be on certain medications like can go ED. So if we don't get your sugars under control, anything else right now is premature.
Is that helpful, Douglas?
Yes.
Thank you so much. Thanks so much. I know you have to get back to clinic. We took a little overtime here. We appreciate you being here with us. We had quite the lively show here today with lots of just a big variety of questions. Thank you so much for being here, Dr. Chen and Dr. Manessis. And we'll see you in about a month, actually possibly during PAD Awareness Month, right? I think that's going to be our next episode. So hopefully maybe we can prepare a little bit more and, do an entire show just focused on driving home the importance of, or the connection between diabetes and PAD, because I think that would be a very timely topic. And then you can give us an update on how far you're walking in the Great Circulation Challenge. For those that are watching on YouTube, make sure you like the video, subscribe to our channel for more great information like this. Thanks everyone for joining.
Thank you, Kim. Thank you for having us and doing whatever you're doing. It's really a great education forum for us, but most important for our patients.
Thank you.
Thank you.